Hello, everybody, and welcome back to our MBME series. This is everything you need to know by the time you finish MBME 27. We finished from 1 to 50, and now we're going to start with 51. These videos take a tremendous amount of effort, many hours to make, so please consider liking and subscribing if you found any of this useful. Whether you are a medical student preparing for the STEP exam, or just somebody who is interested in science, I'm sure that we have some content for you. In this original practice question, we have a 63-year-old man. He's following up 2 months after undergoing a low anterior resection of his rectal adenocarcinoma. He reports new onset erectile dysfunction, there's an intact anal wink, and preserved perineal sensation. Serum T and prolactin is normal. Which of the following nerves was injured? Well, over 70% of men who undergo pelvic surgery for rectal or prostate tumors experience some level of erectile dysfunction afterward. And that's a pretty staggering number, right? And the interesting thing here is that it's not about testosterone. This is going to be your parasympathetic nerves. And not many people know this, but erection is actually a parasympathetic process. You may have heard the phrase point and shoot, and that's very helpful. Point is for the erection, right? That's parasympathetic, hence the P. S is the sympathetic, and shoot is for ejaculation. These pelvic splanchnic nerves come from the spinal S2 to S4. These guys are the ones that point, so to speak. They carry those parasympathetic fibers to the inferior hypogastric plexus. And it's at the inferior hypogastric plexus with a synapse, and then they give rise to the cavernous nerves. All right, so this is what we know about our pelvic splanchnic. We have the S2 to S4, carrying the parasympathetics to the inferior hypogastric plexus, where they synapse and give rise to these guys. The cavernous nerves then go on to release nitric oxide and acetylcholine, and that triggers vasodilation in the arteries of the penis. That's the reason that you get blood that fills the corpus cavernosa. That's what causes the erection. And so the clinical tie-in is that if you have a tumor in the distal rectum, invades near the surgery might get too close and it could damage those pelvic splanchnic nerves. And so you'll have normal testosterone, normal everything, but the answer is going to be pelvic splanchnic nerve because those parasympathetics, S2 to S4, keeps the pelvic floor, and a whole lot more, are going to be damaged, and that causes the lack of the P, which as we know, our point and shoot mnemonic, contributes to the erection and the parasympathetic system. Here's your brief explanation. Genitofemoral, that would cause the cremaster reflex. Renal is the sensation in the groin, and superior hypogastric plexus is the control of the ejaculation. All right, there's 51. Now let's go on to 52. In this practice question, a 28-week gestational age female infant is born weighing 1,120 grams. She requires oxygen and ventilatory support for neonatal respiratory distress syndrome, NRDS. At day 10, thalamic exam reveals abnormal peripheral retinal vascularization with tufts of new capillaries and localized hemorrhages. What is the most likely mechanism? So to answer this question, we need to know a couple of things. First of all, there is this thing called the vascular endothelial growth factor, VEGF. And this is going to interface with our receptor. Our VEGF receptor is what it's called. And imagine here we have, this is an endothelial cell. What's going to happen is that binding of the VEGF receptor is going to contribute to blood vessel growth. And so if you give too much oxygen to a premature baby, it can actually make them go blind. So do not do that. The reason why this happens is because in preemies, the retina is not fully vascularized yet. That growth is driven by VEGF gradients that naturally pulls in the new blood vessels toward the periphery. But if you flood the premature infant with high oxygen to treat their underdeveloped lungs, then you're suppressing the VEGF. Because think about it, we got all this oxygen. Why are we going to need to have this receptor interaction to contribute to the blood vessels if there's already oxygen delivery? And so the correct answer is going to be the disruption of the VEGF gradient due to hyperoxia. A. So oxygen, yeah, sure, it's good. It'll save lives, but it actually has to be carefully titrated in neonates, especially the tiniest ones. So you should keep the SpO2 levels between usually 90 and 95, not 100%. You got to protect the retina. Let's see, the persistence of the hyaloid, that would lead to leukochoria or persistent fetal vasculature. It's not abnormal peripheral neovascularization. And leukochoria is the white pupil. It's a condition where the pupil of the eye appears white instead of black. Dysgenesis is not a posterior retinal neovascularization problem. And bilirubin toxicity, that causes kernicterus, the basal ganglia. And kernicterus is a rare but preventable form of brain damage that occurs in newborns due to the extremely high levels of bilirubin. And so this bilirubin, which is a yellow pigment that's produced during the breakdown of red blood cells, can deposit in the brain tissue of the baby. And that leads to permanent neurological damage. And this is excreted in the bile. A CMV infection is not the correct answer because chorioretinitis may occur. but it usually presents with your white retinal scars, not your active neovascularization. So what is everything that you need to know about retinopathy of prematurity? I'd say there are a couple of things to look out for. Number one would be look out for prematurity, typically below 30 weeks of gestation. A low birth weight as well, so that's going to be like less than 1,500 grams. You need to have high oxygen concentration. They'll typically just say 100%. And you could also see mechanical ventilation, especially for NRDS, because it's a hyaline membrane disease. And the pathophys is important to know too, where you have an immature retina that lacks the full vascularization at birth. So it's not going to be vascularized. And then high O2 actually suppresses your VEGF. So you're suppressing that with your O2. That's also important to know. Then you get hypoxia, which would then, increase that VEGF, for instance. And that's after you have the O2 withdrawal because of the peripheral retinal hypoxia. And under hypoxic conditions, you have increased VEGF, abnormal neovascularization, and you get fragile new vessels that form, and you get hemorrhaging and fibrosis and retinal detachment. Also, the free radicals are produced during high O2 therapy, and they damage those endothelial cells. And your neovascularization is not anchored to normal tissue like it should be, so it causes, some traction that shouldn't be there. So some signs that you might see when you're examining would be abnormal retinal vessels, hemorrhages, retinal detachment, leukocoria, that's the white people reflex, and blindness if you don't treat it. You'll see a dilated endoscopic exam. You should begin screening at 4 to 6 weeks. Keep it between 90 and 95 SpO2. You can also give bevacizumab, that's an anti-VEGF, or surgical repair if the retinal detachment occurs. And that, my friends, is everything that you need to know about ROP, retinopathy of prematurity. Okay, next, question 53. Here we have a 61-year-old man, admitted with fever, dry cough, diarrhea, confusion after attending a conference. Kidney transplant recipient, patchy infiltrates in the right lower lobe, positive for Legionella. Which drug would impair bacterial DNA replication? Well, to answer this question, I think we should talk about everything there is to know about Legionella. Number one, this is a gram-negative bacillus. It requires a special silver stain for visualization. So it's catalase and oxidase positive. It's cultured on your BCYE, or buffered charcoal yeast extract. It requires cysteine and iron for its growth. You should know it can cause Pontiac fever. You can also get severe pneumonia, patchy consolidation, and the mid to lower zones. Can be seen with things like a headache, cause confusion, diarrhea. Usually the fevers are going to be pretty high. You can usually test this through your urine. Usually you're going to give them Erythromycin, which is especially effective, but your macrolides. But you can also give them fluoroquinolones like levofloxacin and moxifloxacin. And so that's everything you need to know about Legionella for step one, I'd say. But this question is asking what directly impairs bacterial DNA replication. That's the way we're going to solve it. And so our answer choices, we have A, azithromycin. Now that's good. It's effective, but it works by inhibiting 50S ribosome, not the DNA replication. B is isoniazid. So that's usually used for Mycobacterium tuberculosis. It inhibits mycolic acid synthesis. So that's not our answer. Ceftriaxone. So we know that's a beta-lactam antibiotic. So that is not going to treat atypical intracellular pathogens. Linezolid is used for your gram-positive bacteria. An example would be MRSA, and that inhibits your 50S ribosomal subunit. So the answer is going to be ciprofloxacin. And the reason for that is that it's a fluoroquinolone that inhibits DNA gyrase and topoisomerase. And if you inhibit DNA gyrase, that'll prevent DNA replication. So that's going to be effective because Legionella lives inside the macrophages. And because this is intracellular, your regular beta-lactams like ceftriaxone are not going to work. You need something that can get inside and it can shut down the cells. Now, these 50S ribosomes, which could have been a good answer if they didn't specifically ask for something different, are important to know for test A. So azithromycin, that's first line against Legionella, Mycoplasma, chlamydia. Erythromycin causes the worst GI upset. Chlorothromycin is added in H. pylori triple therapy, and it can cause QT prolongation, especially if it's combined with other QT-like drugs like fluoroquinolone that can do that too. And so let's say they were to ask you a different question, like a 34-year-old man is diagnosed with pulmonary tuberculosis. He begins treatment with a combination of 4 drugs, and then he has numbness and tingling. What's the cause of his symptoms? This is rather another one of our answer choices. In the treatment of tuberculosis, we can use isoniazid. And what that does is it will deplete your vitamin B6, which leads to peripheral neuropathy, so it's a pyridoxal phosphate deficiency. And how does isoniazid work? That will target your mycolic acid. And that's unique to tuberculosis's cell wall. But the way it does this is it steals your vitamin B6 and it causes neuropathy. And that's why you give pyridoxine with it. Just like to give these little tidbits along the way because they're all important. Okay, moving on. Question 54. This one we're going to go quick on. It's just borderline. It's a cluster B personality disorder. Can be comorbid with a lot of other things. So the pathophys is maybe genetic, trauma, or the like. Impaired limbic regulation, so you have emotional instability. Poor prefrontal control, so it causes impulsivity. Makes it so you have dysfunctional attachment and trust patterns. Low serotonin. The DSM-5 requires 5 of 9 core features. Mnemonic is I despair. DBT is the gold standard. You can also use SSRIs and mood stabilizers. Here's our easy practice question. Best person ever, worst person. They're splitting. Borderline is the answer. These people can wake up every day with the fear that the people they love will abandon them. It's a horrible condition. They have emotional instability and a fractured identity, so use behavioral therapy. All right, moving on to question 55. Now, in this question, we're going to have a 16-year-old female, history of exercise-induced asthma. She's used her inhaler. Physical exam shows a tremor, which explains that symptom. All right, the reason for that tremor is going to be a beta-2 mediated stimulation of your skeletal muscle activity. So these beta-2 agonists can actually stimulate your sodium-potassium pumps in the skeletal muscle, and they increase muscle excitability, and that causes the tremor. It's a benign side effect of the bronchodilators. And they also shift potassium intracellularly, and that causes hypokalemia. Muscarinic receptor inhibition. If you're inhibiting your parasympathetics, you'd have dry mouth, blurry vision, constipation. That's seen with your anticholinergics. Activation of these receptors, that causes vasoconstriction, not a tremor. The inhibition would cause hyperkalemia, not hypokalemia. And then excess vagal tone, that leads to bradycardia, not tachycardia. Here's, for step 1, everything you need to know about beta agonism. So beta 1 acts on the heart, also the kidney. Beta 2 on the lungs, uterus, vascular skeletal. And so the effects are increased heart rate. For beta 2, we can see bronchodilation, vasodilation. Also tachylysis, that's the suppression of the uterine contractions. Increased lipolysis, also tremors can be seen. And there's also the beta 3, that's like adipose tissue or the bladder, that can cause bladder relaxation. Your beta agonists are the fight or flight, and also they can cause the shakiness. For step 1, you also need to know that there are some short-acting beta-2 agonists, and there are long-acting beta-2 agonists. Short-acting is albuterol, obviously, because that's what you use for asthma attacks, and levobuterol. There are long-acting beta-2 agonists, which is basically what's not albuterol. Examples are salmeterol, formoterol. You can also find systemic beta-2 agonists, terbutaline, that's for preterm labor, and ritridine, but that's not really used very commonly anymore. There's some non-selective beta agonists, so beta 1 and 2, like isoproterenol, and dobutamine is mostly beta 1, and that's used in cardiogenic shock and stress testing. You should also know the mechanism at play here. They use GS, which then increases CAMP, and that causes smooth muscle relaxation, bronchodilation, vasodilation in the skeletal muscle arteries, and metabolic changes as well, like increased insulin, lipolysis, and hyperglycemia due to glycogenolysis, increased sodium-potassium ATPase, which causes the potassium shift in the cells, and hypokalemia. That's how beta-2 activation works. Beta-1 activation increases the heart rate contractility, leading to increased cardiac output and shock. So as you kind of scaffold this material in your brain, you can see that it's used for a variety of different disciplines. In the lungs, it can be used for asthma and COPD treatment, albuterol, salmeterol. In OBGYN, tachylysis is the delayed labor, so terbutaline can relax the uterus. And cardiologically, dobutamine is used in acute heart failure. Isoproterenol can be used for your bradyarrhythmias. It can also cause the electrolyte shifts if you have hyperkalemia. The beta-2 agonists, like albuterol, can shift that intracellularly. And by the way, the reason we give corticosteroids with beta-2 agonists in asthma is because beta-2 agonists treat the symptoms, but corticosteroids treat the cause, right? Beta-2 agonists like albuterol, salmeterol, we know their mechanism of action is increasing CAMP and causing bronchodilation, and so you get a quick relief of bronchospasm. But there's actually no effect on inflammation, which is the root problem of the asthma. So the long-acting ones, like salmeterol, can have increased mortality if used alone because they just mask the worsening inflammation. So you give them corticosteroids like fluticasone, prednisone, because those mechanisms for those drugs is that it inhibits NF-kappa beta, which decreases your eosinophils, decreases mast cells. The effect is reduced edema and reduced airway hyperresponsiveness. So it prevents the exacerbations, improves lung function, etc. Moving on to question 56. Here, a 64-year-old man has a 50-pack year of smoking history, chronic cough, weight loss, recent onset constipation, decreased breath sounds, and dullness to percussion over the right mid zone. Labs show calcium 13, phosphate 2.2, and suppressed PTH. Central mass over the right hilum, plus the diagnosis. The things we're queuing into right here is we have a long-time smoker that shows up with weight loss, cough, and high calcium levels. This is squamous because squamous is always going to be on testes central. It's right near the hilum, and it's going to be seen in heavy smokers. The real giveaway to this is hypercalcemia, because that tumor will secrete PTH-related peptide, which mimics the parathyroid hormone and leads to bone reabsorption, kidney reabsorption of calcium. So if the value is over 12, that's your cue. They'll also tell you about keratin pearls, so it's squamous. And a choice that you might have been thinking about as well is small cell. That's also central, and it is linked to smoking, but it causes SIADH or Cushing's, not hypercalcemia. So small cell and squamous are both central, but this has SIADH associations, Cushing associations, and squamous has PTH-like hormone secretion, and they are central, that's true. Whereas large cell carcinoma, it's out on the periphery and it's undifferentiated and it doesn't secrete those things. And it's out here on the fringe with adeno. Adenocarcinoma is common in non-smokers and it's typically peripheral and it doesn't secrete that stuff. And carcinoid tumors can cause serotonin syndrome, but they're not going to cause hypercalcemia. So here's where we pretend these circles represent our lungs. Small cell squamous both start with S central, large, adenocarcinoma, the periphery. In this next question, a 5-year-old girl is just riding on her bike and she's got a superficial abrasion to her knee. Then the bleeding stops and you see a clot. The final step is due to hepatic production of proteins that are involved in which process? Not many people know this, but your liver is what keeps you from bleeding out. So here's our skin, we get an abrasion. What we'll see first is going to be these platelets. But the platelets don't fill the clot, it's going to be the fibrin that comes later. And if you guys remember these clotting factors cause prothrombin, it can be turned into fibrin, and that is what causes these like fibrin strands which actually develop the clot. Because initially you have a damaged blood vessel, let's say, you got all these little red blood cells popping out. Then we have some platelets which are activated and they clump all these guys together, and then the fibrin strands come in and do the extra solidification and they adhere to the plug and they form an insoluble clot. So it's really that fibrin's job at the end of this coagulation cascade. Of course, the coagulation cascade causes the prothrombin to be thrombin, fibrinogen then to be fibrin, causing that later insoluble clot formation of your damaged red blood cell or your damaged blood vessel. Now, there's some answer choices that are going to try to get you. Like A, activation of protein C. Well, what does protein C do? It's an anticoagulant. It inhibits the clotting, so no. B is our right answer. C refers to TPA, and that helps to break down the clots, so it activates plasmin fibrinolysis, not the formation. And thromboxane, A2, is made by the platelets and it promotes aggregation, not the cross-linking. And E is von Willebrand factor, and that mediates the platelet adhesion to the subendothelium. That's pretty early on. It's not going to be the final clot. So yeah, guys, it's the liver, I tell you. Next is question 57. Now for 57, I want you guys to know that just a few drops ointment will save a newborn's vision. So babies at birth are at risk of a gonococcus conjunctivitis. It's a fast-moving infection that can cause corneal perforation in just days. And that's why every single baby gets topical erythromycin in their eyes. They're not trying to do that like thing from Lion King where you just put stuff on the baby's forehead or eyes. Rather, this blocks your 50S ribosomal subunit. That's how we stop Neisseria gonorrhea from taking hold. So they're just going to ask you about, hey, we got a little baby. We put stuff in on his eyes. What does it do? Boom, see. Erythromycin or macrolides, that's what it does. Cell cross-linking inhibition is going to refer to penicillin. We ain't going to use that here. Kind of a memorization question like, what do you put on the baby's eyes? Macrolide. Eyes, macrolide. DNA gyrase is a quinolone. You should definitely avoid that because why? Quinolones have toxicity. That's why it's not B. And then D, dihydropteroate synthase. That's an enzyme that's needed in folate synthesis. So sulfonamides are bacteriostatic antibiotics that block that enzyme. These urinary tract infections, toxoplasmosis, nocardia, pneumocystis. And what you need to know for answer choices like D is that folate synthesis is essential for bacterial DNA replication. Humans get folate from the diet, and sulfamethoxazole, inhibits hydroxypteroate synthesis. And so this works really synergistically with trimethoprim, which will block dihydrofolate reductase, So it's bacteriostatic when it's used alone and bactericidal when it's used with TMP. That's answer D. Different mechanism. So we'll move on to 58. And let's talk about the key points of apoptosis. There are intrinsic and extrinsic pathways. But both of these pathways, intrinsic and extrinsics, end up activating your caspase, which is a cytosolic protease. In apoptosis, we have a cellular breakdown that causes cell shrinkage, chromatin condensation, membrane blubbing, and formation of apoptotic bodies, which are then phagocytosed. Unlike necrosis, the cell membrane is going to stay intact. So let's imagine we have our cell here. I know, beautiful drawing. Over here on our receptors, we have our Fas TNF receptor. And there's a series of cleaving these caspases. And the big difference between intrinsic and extrinsic does not involve mitochondria, and the intrinsic does. So the extrinsic involves a receptor ligand right here. So there are TNF receptors, Fas ligands, which mediate that pathway. This triggers this initial activation of caspase, and then it further cleaves other downstream executor caspases, like caspase 3, and then it's cleaved, and eventually can degrade the DNA and do other things. And then the intrinsic pathway starts on the inside here. And let's imagine there's some sort of irreversible DNA damage, like UV-mediated damage. But you have BCL receptors, and then you have BAX. When the mitochondrial membrane is compromised, then cytochrome C is released. And that's not ever supposed to be there. So the body's like, oh my gosh, cytochrome C is in the cytoplasm. How did that happen? And then it interacts with your APA-F1 receptors. And then these APA-F1 receptors cause that cleavage of caspase 3. And that's kind of the nail in the coffin for the death of the cell. So it ends here, but externally it can start there, or internally, intrinsically, it can start here. Those are your intrinsic and extrinsic pathways, the best way that I know how to explain that. But the answer is going to be cytochrome C, because once that's released from the damaged mitochondria, it triggers intrinsic apoptosis. Granzyme B is used in cytotoxic T cells in the extrinsic apoptosis pathway. BCL2 is going to inhibit these, along with, BCL-XL and BCL2. These are inhibitors. They're anti-apoptotic. And the Fas ligand is part of the extrinsic pathway. That's what activates your caspase 8. And caspase 8 is the initiator caspase in extrinsic, not intrinsic apoptosis. So knowing these mechanisms is high yield and important for step 1. All right, moving on. Question 59. Here there is a 38-year-old woman with recurrent urinary tract infections. She's got some left-sided pain and fever. Urine analysis shows alkaline pH and numerous magnesium ammonia phosphate crystals. CT scan shows large branching renal stones. Which organism is responsible? Alkaline pH, that's a giveaway. So it's basic. Basic means Proteus mirabilis. Sounds like a Harry Potter spell. It's not Klebsiella, because that's urease positive, sure, but it's not going to be causing Staghorn cells. It's not Enterococcus, that's gram-positive, not urease producing even, so it can't be that, and it does not cause struvite stones. And E. coli is the most common UTI cause, but urease negative. Pseudomonas is opportunistic. It's not known for its stone formations. And what people don't know is that in your little kidneys, some bacteria can just keep growing until it's like the size of coral. Flank pain, recurrent UTI, Staghorn stone. You have to think about what's driving that formation. And it's Proteus mirabilis, urease producing gram-negative rod. So you just get these huge stones that are just ginormous. And it leads to the precipitation of magnesium ammonium phosphates, better known as struvite. The urease raises the urine pH and it makes it more alkaline. And the crystals clump and clump together and it just becomes massive and it hurts. All right, moving on to question 60. Last one of this session before I take a break. We have a 3-week-old male infant brought to the clinic for painless enlarging left scrotal swelling. The mass is soft, fluctuant, and transluminates on exam. There are no signs of erythema or distress. What is the anatomic abnormality? In other words, why is experiencing this scrotal swelling? And to explain, we have to talk about the normal anatomy. You have things like the ductus deferens, goes over the testicle. This, of course, is scrotum. And typically there's a closed processus vaginalis right here. But you can get a non-communicating hydrocele. And that looks the same way, except this processus vaginalis is patent, so it's open. You still get that hugeness there. The communicating hydrocele is caused when they have serous fluid that accumulates within the tunica vaginalis because of the patent process vaginalis. Painless swelling, and it transluminates. Our answer is the tunica vaginalis because of that exact reason. Epididymal cyst, inflammation would cause painful swelling. That'd be really, really painful. Internal spermatic fascia. So cremasteric, these guys right here, These are fascia layers. They're part of the spermatic cord coverings, but they're not involved in hydrocele formation. It's just this guy would be. So that's the painless transilluminating scrotal mass. It's going to be tunica vaginalis, as the process of vaginalis fails to close, causing communicating hydrocele. And sometimes people don't realize the testicles don't just drop, they drop a line down with them. Before birth, a testicle starts really high up in the belly. It's actually near the kidneys. And then they start to descend into the scrotum and they pull down the pouch of peritoneum, which is the lining inside the abdomen, with them. And that pouch is called the processus vaginalis. And normally that pouch closes off after birth. Once the testicles are in place, you're good to go. The opening between the abdomen and the scrotum will close. If it closes properly, then the testicles stay surrounded by a small remnant that's called the tunica vaginalis, but no fluid can get in. However, if that opening stays open, it's called a patent processus vaginalis, and you get peritoneal fluid from the abdomen. It leaks into the scrotum that causes a painless bulge, and it's a communicating hydrocele. So why does it light up? Well, a scrotal swelling is full of clear serous fluid, and so light can just pass right through. So get a flashlight, and it glows red or maybe orange. It's going to be a hydrocele sign. Now, non-communicating means there's fluid that's just trapped in the scrotum, but it's not connected to the abdomen anymore. And that happens during fetal development because it still closes properly, but before it closes, the fluid gets trapped inside the tunica vaginalis, which is the sac that's around the testicle. And the fluid will just stay there for a while, but it won't refill because there's no opening or connection. And so it's still going to be scrotal swelling that's painless, it transilluminates, and it's usually stable or will shrink over time. All right, folks, that is NBME 27. These are your first 10 questions of this second part. If you guys find the series helpful, like and subscribe. I'm going to take a break. We'll see you in the next one.